Thanks very much, Nicole, and it's my pleasure to talk to you about am I a candidate for DBS and what that means. Just briefly, some disclosures to be aware of. We do receive educational grants and fellowship funding from these companies listed here, and I personally also receive research funding from the University of Colorado and Medtronic, as well as have received stipends from Boston Scientific and Insight Tech, but we will not discuss any specific information related to these disclosures today. So just a brief overview of this webinar series. This is talk number 2, Am I a Candidate for DBS? Last month, we heard from Dr. Aslam about an overview of what is deep brain stimulation. Next month, Steve Ogeman from the Department of Neurosurgery will talk about what are my options for DBS. John Thompson, a neurophysiologist, that's a key part of our team, will talk about what are local field potentials or LFPs and why are they important. And finally, in May, Drew Kern and our DBS nurse navigator, Mari Kelly, will talk about what's next in the future of DBS. So what we'll talk about today is, am I a candidate for DBS? And we'll try to answer some of these W questions. The what, of course, is DBS. But we'll try and talk about who is the right person for DBS, when is the right time for DBS, why do we think about doing DBS, and where might we think about doing DBS. We'll focus in particular on the movement disorder-related indications for DBS, which include Parkinson's disease, essential tremor, and dystonia. It's worth noting that there are certainly other indications for DBS, including epilepsy, things like obsessive compulsive disorder, but we'll focus really on these movement disorder conditions and particularly on Parkinson's disease. So let's start with Parkinson's disease. Who is the right person for DBS? I think that really revolves around 3 pillars, which are 1, having the correct diagnosis, 2, being at the right level of severity, and 3, verifying what we call the levodopa response, or that people's Parkinson's symptoms do indeed respond and improve with levodopa or Parkinson's medication. The correct diagnosis means that someone has Parkinson's disease, or what we call idiopathic Parkinson's disease. And that means just Parkinson's itself. It means it is not Parkinson's that's caused by something else. One of the more common other causes of symptoms would be certain medications, in particular medications that are used to treat depression, bipolar depression, or schizophrenia, which, because of the way that they work, can cause symptoms that mimic Parkinson's disease. It's also important to evaluate or think about other potential conditions which can cause similar symptoms. And these conditions, some of them are listed here. They are in particular progressive supranuclear palsy or PSP, multiple system atrophy or MSA, and dementia with Lewy bodies or DLB. All of these conditions have many of the same symptoms of Parkinson's disease. They cause stiffness of the muscles, slowness of movement, in some cases tremor. They cause trouble with walking and balance, but they often have their own unique set of symptoms that are different and that can be separated out from Parkinson's disease. It takes someone who's had a lot of experience seeing these conditions and seeing Parkinson's disease to be able to tell them apart. What we don't have is great tests, either blood tests or scans or something like that, that can easily tell apart these conditions. And so the best way to evaluate and rule out one of these other conditions would be to be evaluated by an experienced movement disorders neurologist. That's a neurologist who has a particular training and focus on movement disorders in particular. And it's important to rule out or to look for these other causes of these symptoms, not just because DBS won't help these people with these conditions as much, but there's actually evidence that it can do harm. And some people, for instance, who inadvertently are treated with deep brain stimulation for something like MSA may actually do worse faster than if they hadn't been treated with DBS. So it's really important to think about whether it's possible that someone would more correctly be diagnosed with one of these other conditions besides Parkinson's disease. What is the right level of severity of Parkinson's to go through DBS? This relates primarily to what we call advanced Parkinson's. It's worth noting, and I have that in quotes, because there's not a single agreed upon definition of what advanced Parkinson's is. But in general, we think about a stage where people develop motor fluctuations. What this image is showing you here is the amount of drug or levodopa in your system after taking a dose, which we expect to rise pretty quickly and then eventually trail off. And in the green area, that represents where someone might feel good, like their symptoms are being well treated or well controlled by the medication. Early on in Parkinson's, that gap is pretty wide, and people spend most of their time feeling good. They take the medications, they seem to work well, they last generally throughout the day, and they don't need to take medications terribly often, typically 3 times, maybe 4 times a day. As the disease progresses, though, that gap between too little and too much medication becomes narrower, and it might become more difficult to feel like symptoms are well treated or well controlled by medication. It might take longer for the medications to kick in. It might last less time or a shorter amount of time, and it feels like the effect of the medication wears off in between doses. There can also be a problem at the top of this curve here, where when the medication is at its highest level in the body, people will develop dyskinesia or what are uncontrolled writhing or dancing movements. The typical example of this is the type of movement that Michael J. Fox has. And again, as the disease progresses, that gap becomes even narrower and narrower, such that people spend even more time either with too much medication in their system or too little medication in their system. And we do things to try to address this, like have people take more medications or take them more often, use additional medications meant to help boost the effect of the levodopa, or use extended release versions of the medications. But still, just due to the progressive nature of the disease itself, people tend to move in this direction where it becomes more and more difficult to spend time in this green area where you feel good, and it's easier to spend more time either with too much or too little medication in your system. And I wrote here that this is true despite optimized medication therapy. Someone who's experiencing these ups and downs of their symptoms, but only taking medications 3 times a day or hasn't tried adjusting medications should again be evaluated by a movement disorders neurologist or someone who's familiar with how to use these different medications that we have available to us and how to combine them to achieve the best possible effect. But again, we still expect that with time, this becomes more and more difficult to do. And that's the point when we think about deep brain stimulation. I mentioned that there's no single agreed upon definition of what advanced Parkinson's means, which is a little counterintuitive because if you look at the FDA labeling or indication for deep brain stimulation, it's indicated as a treatment for advanced Parkinson's. But what does that mean? Again, you could ask probably 5 different neurologists and get 5 different answers. One handy rule of thumb, I think, is the 5-2-1 rule. That means that people are taking at least 5 doses of medication throughout the day, and that despite doing that, they're experiencing 2 hours of off time or times when the medications aren't working, and or they're experiencing at least 1 hour per day of bothersome dyskinesia, those extra dancing or twisting movements. And people who fit this criteria are generally probably in the right stage to think about DBS. Is there such a thing as too severe, though? We know that with time, other symptoms of Parkinson's start to become more prominent. Some things that we think about are whether people experience more symptoms in the middle of their body. That would include trouble with walking or gait and balance, changes in posture. This person on the right here obviously has a pretty severe curvature of their upper body that is reminiscent of the Leaning Tower of Pisa. And so this condition is called Pisa syndrome. Or they have significant changes in their speech. Their speech is very slurred, very difficult to understand. This is a difficult conundrum and one that takes a thoughtful and case by case evaluation. But it's worth mentioning that many of the times these are symptoms that do not change much after DBS. And for someone whose real problems are with the way that they walk, their balance, falling often, the way that they speak, DBS may actually not help them very much because it may not improve those symptoms. I'll say too, again, that this is a case by case consideration. There are some people who have significant trouble with their walking or gait, and it gets a lot better when they take their medication. And so, if we could prolong the effect of their medication, we could probably improve their walking significantly. That actually might be a good person to think about DBS for. Um, Again, some of the more severe posture changes, like this gentleman here, in some cases do actually improve with DBS. And so, again, there's no hard and fast rule, but it's worth noting that this is something that your neurologist is thinking about whether someone has some of these more advanced or severe symptoms that, at least in some cases, may not respond well to DBS. And the last pillar of who is a right candidate for DBS for Parkinson's disease is that their symptoms respond well to levodopa. By and large, DBS will do what levodopa or what Parkinson's medication does for people. It will just do it more consistently and it will prolong the effect of their medications. To verify that, we conduct that test in the office. So we call it a levodopa challenge test, where we ask people to come in after stopping their medications, typically for at least 12 hours, and we see them in their most severe state. And then in the office, we have them take medications and see how much their symptoms improve. Again, the general rule of thumb is that we expect or hope to see a 30% improvement in the severity of their symptoms after taking a dose of levodopa. If it's 29%, that's obviously not something where we would automatically stop someone from getting DBS, but the typical number we look for is 30%. There is an important exception to this rule, and that is when it comes to tremor. For many people who have tremor due to Parkinson's disease, the tremor doesn't improve much with medication, but we know from experience that it will improve significantly with DBS. So this is the case where DBS actually does better than the medications do, whereas for other symptoms like stiffness and slowness, DBS will do about as well as the medications do. So if someone has severe tremor or a lot of tremor, and we don't necessarily see that 30% improvement in their symptoms, that might actually still be a good reason to go ahead with DBS. There's some evidence too that people may do better with DBS if they have a better improvements with levodopa. So someone whose symptoms improve by 50 or 60% may actually stand to benefit more from DBS. So it's not that you need to benefit more, but there's at least some reason to think that people whose response to levodopa is even more profound than 30%, they may do better with DBS. Moving on to when to think about DBS for Parkinson's disease. The classic rule that most people go by is that someone should have Parkinson's for at least 5 years before we think about DBS. That's for a couple reasons. One, because that's about the amount of time or about the earliest amount of time you might see someone develop those fluctuations or those ups and downs in their symptoms that are caused by medications. And so doing it any earlier wouldn't really make any sense. The other reason is that it's helpful and easiest to exclude those other conditions I mentioned after about 5 years. In those first 5 years, Parkinson's and the other conditions I mentioned, PSP, MSA, etc., can look pretty similar, but by about 5 years, it should be easier to tell apart someone who has Parkinson's versus someone who has one of those other conditions. So that's the typical rule, is that we want people to have Parkinson's for 5 years before we proceed with DBS. But more and more, DBS has been done earlier and earlier in the course of Parkinson's. And then there are several studies that have looked at, should we go earlier than 5 years? This graph is from one such study that looked at patients and put DBS in within 4 years of their disease starting or within 4 years of starting medications. And those people generally did just as well without any of the complications that you might worry about. For example, the incorrect diagnosis coming up. There's even some evidence that those people might do better. On the left panel here, you're looking at the severity of people's symptoms over time, so over 5 years. The black line is the people who got DBS, and the red line is the people who went on only medications without DBS. And they generally did about the same. These lines move at about the same rate. We expect a gradual worsening over time in their disease severity, and that was true for both people with DBS and on medications. But interestingly, if you look only at the severity of people's tremor for Parkinson's, the people who had DBS actually got better over time in terms of their tremor, whereas the people who were on medications continued to get worse over time. So maybe it's the case that DBS could actually change the course of Parkinson's to some degree in these people for whom they undergo surgery earlier on. Why should someone with Parkinson's go through DBS? Well, this is something we think about. We talk a lot about people's goals or their expectations for DBS, and we want to make sure that what we think DBS can do for people aligns well with what they expect it to do for them. What we know from studies and from experience is that DBS can do generally the following things. It can decrease the amount of dyskinesia people have. It can provide longer periods and better mobility or better on times. Again, about the same as when the medications work, but more consistently throughout the day. We know that DBS improves people's overall quality of life. And for many people, it allows them to take less medication than they were taking before surgery. So these are the things that we would tell people we expect to see after DBS. And if someone is generally in agreement or is expecting these things to happen, that's a good reason to go through DBS. Reasons people might ask about DBS that we cannot provide would be, someone who expects DBS to make them feel like they did before Parkinson's. It doesn't do that. It again makes people feel about as good as they do when their medications are working, or to slow down, to stop, to reverse the symptoms of Parkinson's. I know I just showed you some evidence that people's tremor may do better over time with DBS, but in general, we do not think of DBS as something that slows down or reverses the course of Parkinson's. It's still a progressive condition that we expect to gradually get worse over time. I'll mention too just a little bit about non-motor symptoms. We, of course, focus a lot on the motor symptoms of Parkinson's, tremor, stiffness, slow movements, balance problems. But people with Parkinson's experience a whole range of other non-motor symptoms. These include things like trouble sleeping, pain, mood disorders like depression and anxiety, thinking and concentration problems, hallucinations, trouble controlling the bladder. Really, any part of the body can also be affected by Parkinson's. And for some people, those symptoms are actually much more severe or more bothersome than the movement-related symptoms. We do know from studies that some of these actually typically improve with DBS. Sleep often gets better after DBS. People usually experience less pain after DBS. Their mood is often better. What we don't know is how best to predict how much those things will get better or how specifically to improve them with DBS. And so for that reason, it's not something we usually tell people to expect with DBS or we think of as being a good goal or a good hope for DBS. If someone wants to go through DBS to fix their sleep and their sleep only, that's probably not really a good reason. The sleep may get better, but it sometimes may not. And it's hard to know exactly how much it will get better for any specific person. So for that reason, I've written here that if those non-motor symptoms are really the most problematic aspect of Parkinson's, DBS may not be the best option, at least for now. Just a little bit about essential tremor. So separate from Parkinson's, people who have tremor of the hands, sometimes the head, neck, and voice as well, we perform DBS. The right person for DBS is someone who still has a disabling tremor despite receiving appropriate doses of medications. And disabling means that the tremor causes trouble in day-to-day life, eating, drinking, speaking. It may be embarrassing or distracting in social situations. And that they've also at least tried appropriate doses of medications. And what an appropriate dose is again, somewhat up to you and the neurologist you see. But someone who's tried only a very, very small dose of a single medication probably isn't the right person for DBS yet. It's worthwhile to try a higher dose of medication. Or sometimes people have significant side effects from some of the medications we use to treat tremor. Usually the most common things are that they can make people sleepy or groggy or sedated. And so if someone really can't take the medications due to those side effects, that might also be a good reason to think about DBS. When is the right time for someone with tremor to go through DBS? Again, there's not as much in the way of clear guidelines, but typically 3 to 5 years. We do not think about doing DBS right at the beginning of tremor. It's usually not severe enough. And more often, this is something that people have dealt with for many years or decades before they decide to come in and think about DBS. Dystonia is a separate movement disorder that causes abnormal twisting or pulling of muscles or muscle groups in the body that leads to those body parts to contort themselves in abnormal ways. The right sort of person to undergo DBS for dystonia is someone that has what we call primary dystonia, meaning that's the disease itself. It's not caused by something else like a brain injury, a stroke, or some other condition that can sometimes lead to these types of movements. We think that people should have what we call generalized dystonia or segmental dystonia that involves multiple body parts, or cervical dystonia that involves the neck, where people's neck will twist or contort itself. There are certainly other forms of dystonia, although it's not as well studied and not as well understood how they respond to DBS. And so I've written here that some of those indications are off-label on a case-by-case basis. We may think about doing DBS for those situations, but it really depends on one person at a time and a thorough evaluation by a movement disorders neurologist. When should people with dystonia go through DBS? Generally, if they've tried other medical therapies, there are a whole range of medications that can be tried for dystonia. In some cases, especially with cervical dystonia in the neck, Botox or botulinum toxin injections is the first thing we try. And if those therapies are ineffective or cause side effects, then we think about DBS. And again, I'll say too that the timing may depend on what exactly type of dystonia someone has. Many times people with cervical dystonia deal with it for several years or decades before they decide to think about DBS. In some more severe cases, including some that are caused by genetic mutations, it's actually better to do DBS sooner rather than later. And so sometimes that's even young people and sometimes even kids that get DBS for dystonia in this case. So who's not a good candidate? And again, most of these things or many of these things relate to Parkinson's, but they would apply to other conditions like tremor and dystonia as well. Someone with significant memory or thinking problems, what we call dementia, is probably not a good candidate for DBS. That's for a few reasons. We know that people with dementia struggle to participate in the process of DBS. DBS involves a lot of back and forth between the patient and the neurologist about what's working, what's not working, what problems you're having. And someone who can't provide that will generally not do as well. And we also know that we can't fix or improve dementia or thinking problems with DBS. And so someone who's really struggles with that aspect of Parkinson's, they probably wouldn't notice as much benefits as in terms of the benefit on their tremor or other symptoms because the dementia will still be there. I'll say again that someone who's not got the right diagnosis and may have another condition would not respond well to DBS. Someone that has conditions that make surgery unsafe, like significant heart problems, bleeding problems, breathing problems that make surgery risky, again, not a good idea to go through DBS. Someone that's got extensive shrinking of the brain, this is a thing that happens normally as we get older, and usually beyond age 80 or so, the brain might be shrunken or smaller than it once was, to the point that again surgery becomes risky. There may be a higher risk of bleeding or stroke or other complications of the surgery. And so we really think hard about whether someone, again, typically beyond age 80, is the right candidate for DBS. Someone, again, who does not expect the right things or has unrealistic expectations about what DBS may provide for them, not a good idea. And people with other significant medical or psychiatric conditions that include depression, which can be a significant aspect of Parkinson's disease, probably not a good candidate for DBS. So taking all those things together, the standard sort of evaluation that someone might go through if they were thinking about DBS would be an evaluation by a movement disorders neurologist, primarily to verify that we have the right diagnosis, but also to talk about what someone might expect, what their goals are for DBS, how DBS might help them, and other ways it might not help them to clarify what people can expect with DBS. In the case of Parkinson's, we do that levodopa challenge test, or what we call off-on testing, where people are seen both without medications in their system and with medications in their system to verify that their symptoms respond well to DBS. People go through detailed cognitive testing, again, to verify that we haven't missed any significant memory or thinking problems or dementia. You'd have an MRI of the brain to help visualize whether there's been any significant shrinking of the brain, anything else that would make surgery risky, as well as to help plan the surgery and identify the part of the brain we want to put the DBS in. And people have a consultation with a neurosurgeon, of course, to talk about surgery, risks, other options. On a case-by-case basis, or at our center, people often meet with a palliative care specialist or a social worker, again, to help provide the right support and guidance as you go through a major life-changing event like DBS. I'd emphasize too that a DBS evaluation is a multidisciplinary or group effort that involves, of course, neurologists, neurosurgeons, radiologists who are looking at your scans, psychologists who do the memory and cognitive testing, sometimes rehabilitation experts if there's other factors that may affect people like back issues, leg weakness, neuropathy, those sort of things that can exist in addition to Parkinson's. These people are thinking about whether you've gone through other non-surgical treatments, other medications, other options, whether we have the right support in place for someone who's going through surgery, whether their expectations are realistic, and whether other medical conditions have been thought about and addressed. And then lastly, to talk a little bit about where to go for DBS. People generally have many options for where to go for DBS surgery, especially in a large city like Denver. I would just emphasize that at the University of Colorado, we are a Parkinson's Foundation Center of Excellence. We have the largest comprehensive movement disorders team in the region, a multidisciplinary and collaborative effort that involves all of those types of physicians and other providers I mentioned previously. Our providers are licensed not only in Colorado, but also in New Mexico and Wyoming, and therefore able to provide care to people in those states. We offer DBS surgery with all three available devices or manufacturers that are available in this country. We always have new research studies, the latest updates on technology and DBS capabilities available. And then uniquely, I think some things that are special about the University of Colorado are our neuropalliative care section, a group of neurologists that are also focused and trained on palliative care, again, kind of that supportive care, and a real focus on the genetics of neurologic diseases as well. We're learning more and more about how genetics may play a role in Parkinson's, but also in other conditions like dystonia. And that's a real consideration for us as we move through DBS and as we learn more about how genetics may influence these conditions. So with that, I'll say thanks very much for your attention. I'd be happy to take any questions if